Hello, my name is Robert Zeiser. I'm the director of the Division of Stem Cell Transplantation at Freiburg University Medical Center. And today I will talk about steroid-refractory chronic graft-versus-host disease. Chronic graft-versus-host disease is a disease that occurs after allogeneic stem cell transplantation. And the first-line treatment, according to the EBMT guidelines, are corticosteroids at a dosage of 0.5 to 1 milligram per kilogram body weight, combined with local measures and supportive therapy. In patients where there's no response to this therapy, treatment with a treatment of at least 4 to 8 weeks, we call these patients steroid refractory. The second-line treatment that is currently approved in the EU is ruxolitinib for patients that fail corticosteroid therapy. If there is no response to that, other therapies are being considered, including ibrutinib, belumosudil, axatilimab, ECP, or in selected patients, MMF or mTOR inhibitors. And what is the basis for this treatment that we give to the patients? There's different mechanisms of action. The therapy that I mentioned first is ruxolitinib. This drug interferes with Janus kinase 1 and 2 signaling, which is downstream of multiple cytokine receptors that play a central role in chronic graft-versus-host disease, including interferon gamma, IL-6, IL-2, and so on. And this inhibition of JAK kinases leads to decreased phosphorylation of STAT1 and STAT3 proteins, which are transcription factors that translocate to the nucleus and initiate transcription of pro-inflammatory genes. This process is prevented, and it's a reversible prevention. So once the drug is taken off, the signaling can occur, and these immune cells are not depleted by this therapeutic intervention. Another kinase inhibitor is ibrutinib. It blocks BTK and ITK, which reduces signaling downstream of the B cell receptor and the T cell receptor. And it is approved in the United States by the FDA for chronic graft-versus-host disease that has not responded to corticosteroids. And in Europe, it is much less frequently used. Then another drug that is based on kinase inhibition is belumosudil. Belumosudil interferes with the activity of the Rho coiled kinase 2, or short ROCK2. ROCK2 is a central mediator of signaling downstream of growth factors, cytokine receptors, and integrins, which are important for cell migration. And this blockade then reduces the activation of STAT3 proteins, while it promotes STAT5 activation, leading to a regulatory T cell phenotype. And thereby, this intervention reduces collagen and extracellular matrix production, recruitment of myeloid cells, which are dependent on ROCK signaling with respect to their migratory activity. And belumosudil has been tested in clinical trials. For example, in the ROCKSTAR trial, where belumosudil was randomized into two dosages, 200 milligram once a day or twice daily. And this trial showed a high overall response rate during the 12 months of treatment. And secondary endpoints were safety, duration of response, modified symptom score, failure-free survival, and overall survival in these patients. And this trial led to the approval of belumosudil in the United States. In particular, since also patients that responded not anymore to ruxolitinib or other therapies were included, which is currently high unmet medical need, given that there's a fraction of patients that is not responding to ruxolitinib. The overall response rate at week 24 in the REACH3 trial to ruxolitinib was 49.7%, which indicates to you that the other 50% need alternative therapies. Interestingly, this improved failure-free survival that was observed in the REACH3 trial was maintained also after a 3-year follow-up, as recently published in the Journal of Clinical Oncology this year, where the ruxolitinib arm had still a higher duration of response. Interestingly, here in patients that crossed over from the BAT arm to the ruxo arm still experienced high overall response rates. Then I come to the third drug, the CSF1 receptor inhibition with axatilimab. This is based on mouse data published in the Journal of Clinical Investigation in 2014, where it showed activity against chronic GvHD features in the preclinical model, like fibrosis, collagen deposition, loss of hair follicles, and so on. And that was translated into a clinical trial published by Wolf et al. In the New England Journal last year, where 3 different dosages of axatilimab were compared. In the lowest dose, 0.3 milligram dose group showed the highest response rate with 74% response in heavily pretreated patients, which was a very impressive response pattern. And in particular, lower GI, upper GI, and esophagus responded well, which are difficult to treat organs affected by chronic GvHD. Also in lung, chronic GvHD responses were reported, and that led to the FDA approval of axatilimab for advanced chronic GvHD that has been refractory to at least 2 prior lines of treatment. So in conclusion, we have in total 4 FDA-approved therapies for chronic GvHD: ibrutinib, belumosudil, ruxolitinib, and axatilimab. And the future question will be, what are good combinations of these therapies? Can they be combined with each other or with other interventions that are less have a different mechanism of action, like extracorporeal photopheresis, which has also shown to be very active against chronic GvHD in many different clinical trials. With that, I'm at the end. I thank you for your attention and hope you enjoyed the presentation.